This is Mark Bramer with iCare Analytics, who offer the license and provide support for the patented care probability of disease engine. As I mentioned in the earlier session, the care engine takes a provider's internal patient population of their historical medical diagnoses, as recorded in their claims data, together with our external research database as two key components for this disease prediction processing. The creation and use of CARE's research database is critical. This large database has proven predictive power. It is based on a large patient population across all demographics, locations, and medical conditions. It spans a sufficient number of years of recorded, sequential, multiple visits that include multiple diagnoses. It fills in the data gaps when using smaller data sets from our clients for processing. It is also worth mentioning the significance of a recent decision by the Centers for Medicare and Medicaid Services to enact a new policy in September that for the first time will allow innovators and entrepreneurs to access CMS data such as Medicare claims. This data set of over 100 million lives with their medical histories, when combined with the additional claims data recorded from patients under private insurance coverage, allows us to validate the predictive power of the CARE PD engine in ways that were not practical in the past, and be able to set up an implementation of our engine with the ability to process any data set from any client at any size at any time with strong predictive power. This is especially valuable when a provider is considering taking on the care of a new patient population, say under a bundled or negotiated payment plan with an insurance payer. In most cases, this new patient population comes with historical claims data for evaluation purposes. Categorizing these patients into buckets of low, medium, and high risk based on general disease prevalence statistics is insufficient. The CARE engine uses both data sets to determine patterns of disease predictions and progressions used in its probability of disease metrics with predictive power. The following slides are examples of renderings that are possible when connected to the CARE engine and its data results. Obviously, we are not using any actual patient data, so values are merely representations for demo purposes. But perhaps these dashboard screen captures will serve to illustrate ways to use CARE's results in meaningful ways within your organization. The selectors on the left could be ways to visualize and/or report on CARE results, as well as connect or align these results with other internal clinical data or financial information. There are any number of published data sets and metrics in the public domain that can serve as useful baseline comparisons and benchmarks for ongoing analytical purposes. Here is a rendering of a single patient selected from the patient population view on the prior slide, where their future at-risk conditions are listed in rank order based on 4 visits that produce 12 diagnoses associated with 6 unique diseases. One could even associate the probabilities in the far right column to scores on a 100-point scale to facilitate integration purposes with other clinical data sets. This rendering lists each predicted disease condition by ICD code, its description, how many patients have been predicted to develop this disease in the future, and the overall likelihood of each disease occurring in the future from the population data set after processing. One could easily display graphical representations of CARE data, for example, a bubble chart depicting a distribution of the number of patients relative to their probability of developing a specific disease condition like benign intracranial hypertension. A population-level financial pro forma could be constructed by linking disease conditions to expected payments and/or expected costs from either published benchmarks or actual estimates generated from internal systems. Once this rendering is designed, then a patient-level view could be constructed based on their positive or negative contribution to gross margins based on a break-even hurdle. In this example, I tried to think of a combined use of scores and probabilities. I'm going to borrow from Anthem, who gives this presentation to explain the use of CMS scores in the risk adjustment process for payment reimbursement based on a specific condition, in this case, a type of diabetes. CMS publishes their risk score for this ICD code associated with diabetes as 0.162. They add a demographic score based on sex and age as another adjustment of 0.44, which totals a risk-adjusted factor of 0.602, which is essentially a way to adjust from a standard baseline of 1 based on the general population. There is a published community rate associated with this condition of $800, which is the standard payment offered to a care provider, and the math works out to a total reimbursement of $481.60 due to the adjustment methodology under the Medicare Advantage HCC program. One way to estimate future payments associated with future medical conditions of any population under care would be to substitute the diagnosed codes with at-risk probabilities and their codes and continue the math. As always, a provider can petition for adjustment in their favor if they can substantiate and document that they suffer from adverse selection and that they are taking on greater risk than the risk-adjusted factors suggest. I'm sure you all may have other appropriate applications of meaningful use cases in financial settings as a user of care. Lastly, in this example, I am suggesting ways to continue the comparison of baseline metrics, commonly found in the public domain, with care predictions, like mortality rates associated with certain diseases. Here we cited the CDC.gov website, whereby data can be directly linked or downloaded into the care database for reporting purposes. In any event, we've come to the end of my presentation. I want to finish with a proposal for a way forward to give you all something to think about in the weeks ahead. During the next 3 to 4 months, with your permission, my team will process a data set of your patient population at no cost to you. We can provide you with data specs to prepare and send to us, a comma-separated file, CSV file, of patients and their visits and diagnosis history, usually found in the claims data in your system or with your claims vendor. We will process this file with the Care PD engine and produce results that we will then display using a dashboard tool similar to what you've seen in the presentation. Then we can schedule a visit and make a presentation to your team of our results. You can use the results in any way you wish, and if there is interest in continuing to use such information, then we can propose a licensing arrangement that makes sense. No risk, no cost to get started. Well, thanks again for spending this time with me to learn more about our breakthrough technology that will become standard equipment to help strengthen population healthcare risk management activities now and in the future. Feel free to reach out to me anytime to talk more about the Care PD engine and how we might work together in the months and years ahead.